Professor Chris Anderson, who's an honorary professor and alumni of UCT. He's a clinical lead for prostate and kidneys robotic surgery at St. George's University in London. Was also a member of the European Association of Neurological Surgery. We were just doing a debate here on whether there is still a role for transrectal ultrasound guided biopsies. If you can just share your comments on that and your experience in your unit, and we'll move over to your talk.
Sure. I mean, morning everybody, and I'm very honored to be. Morning everybody, I'm very honored to be here. Great to be back in the Prof here, where I studied my urology, and pay tribute to all the previous lecturers and consultants who taught me everything I know. So I'm very grateful. It's always nice to come back. So in our unit, to be very honest, transrectal biopsy has just about disappeared. Nobody does it anymore. It's all we do. Basically, day case biopsies focused, so targeted. So it's really interesting, and that process has probably taken about probably about 5 years, and it's literally disappeared. So we used to have lots of interventional radiologists. The radiologists did the biopsy, not the urologists in our unit. And in most hospitals in London, it's like that. However, outside London, the urologists did them. And where that relationship prevailed, the interventional radiologists don't even do it anymore. The only time we do it will be for a patient who is Bond or high-grade disease, who the oncologist need tissue for in order to have treatment options for subsequent systemic therapy, because they will never do it based on just a DRE and an MRI alone. So that's probably the only really time we do it.
Yeah, no, thanks a lot. Chris, for that comment. It's a resource thing. I mean, the clinical cancers, and I mean, you obviously need to do an MRI.
The vision put forward by the National Health, but it's not practiced everywhere as efficiently as that. But the idea is, it's a walk-in clinic, you have your MRI and you have a biopsy the same day. We quite often schedule the MRI the day before, and because there are other issues, like you need to sit down with the radiologists and have some peer review, so to speak, when it comes to the MRIs, not just believe the report, because there are nuances in interpretation and that sort of thing. And also, if you put two interventional radiologists together, they might slightly differ in their approach. So we tend to have the MRI first, discussion, and then plan the biopsy list. And we have a separate biopsy list, but it's a walk-in, walk-out and a local anesthetic. I think the local anesthetic component has been over-egged a bit, because I think there are quite a few patients who are not appropriate for local anesthetic. And a criticism of our system is that we assume everyone's going to be fine with local anesthetic. And of course, sometimes the patients can't tolerate it. It's a bit of a moving target, and you might not reach an optimal experience. But anyway, that's just a side issue, really. But I think that if you have the choice, you've got to pick your customer, local or sedation, depending on what you think is right for the patient, and then you go ahead. But yes, MRI first. We started doing that a number of years ago, and I think there's no doubt that's the right way to go, because we practiced exactly as you're describing. In the old days, we always used to do everything first and MRI last, but of course, there's artifact, and it's almost ridiculous to try and interpret an MRI after someone's poked needles into it.
Yeah, no, thanks a lot for that, Chris. we've started doing, like you were saying just now, because of resources, we actually do it in the setting of previous negative biopsies. We're currently doing a project, Justin Hollett's project, where we actually do these patients under local. And I think the pickup rate has actually been, I don't know the data because it's got the data to analyze, but I think it's been quite good with their experience, in fact, under local. But you're quite right. You need to pick your patients, because if they move, then, it's a complete disaster. You're not going to get the benefits. But thanks a lot for that, Chris. If you're ready for your slides,
sure. Do you want me to stand?
Yeah, so the guys can see. Thanks a lot. Keep your mask.
Good. So, morning, everybody. I just want to talk about training. Obviously, that is very relevant, particularly to the South African situation now. And how do I? Want me to do this one? Maybe the mouse. Oh, spacebar. Okay. It's not moving. I'm sorry. Sorry, we're just struggling to advance the slide here.
Something has died.
Okay, that's fine. That's the second slide.
It's not.
Well, why don't you sit with the mouse and then do next? I'll just ask next.
No? Which one is it? That one? No. That should be sharing, and let's see if it moves. It doesn't move. Why is that? Oh, it is moving.
It's sharing.
Yeah, it's working now. Okay,
Have you got feedback from everybody? Can they see that there?
Yeah, it is working on the mouse.
On the mouse?
Yeah.
Left.
Just use the wheel.
Oh, the wheel. Okay. All right. So, yeah. So I think we've moved away from the Halstead model of C1D1, C1do1, teach one. A lot of people will be familiar with that approach, but it really has, there's no place for that in this modern era, really, because the patient is not the best training model. And I think that's a really important point. We're now starting to develop lots of different tools, and you can learn basic skills, advanced skills, and also procedural training in all the modalities that we're going to talk about. So initial steps, if you are wanting to do robotics, you can't take the whole registrar fraternity and say, okay, let's all go and do a course and so on. There's got to be some understanding of what goes on in theater. There's got to be a realization what laparoscopic procedures are all about. Trocar placement, patient positioning. They've got to understand steep head down. What does that mean? The lateral jackknife position. What does that actually mean? And you can only really get that from having some experience. So you need an initial awareness and case observation, etc. Then there are other opportunities once you've done that. So case observation is obviously the introduction to this whole realm, and it's really, I cannot emphasize really how important it is. There is, interestingly, not much data out there to show that it does improve surgical ability, but I think that's because the hypothesis hasn't been tested well enough. It allows familiarization with the procedure, and that is the most important thing, is that there's this awareness, a will, a desire, and understanding. That's all very, very important, and a passion for the subject. It's important to be able to use case observation as a way to imitate what you see being done. And I always cite the example of when I went to the UK in the 90s. I assisted Roger Kirby with about 120 prostatectomies. That's it, just open prostatectomies, 120. And I used to be able to, in my sleep, sort of remember every step. And in fact, when I came to do it, it was definitely true that my learning curve was truncated because I absolutely knew what to anticipate next. So I was purely imitating, and that's why it's really important. It gives the opportunity to ask questions and to feel comfortable to ask questions and so on. So e-learning is now becoming very popular. So if you're in Europe, it's always the prelude to doing any form of training. So it simplifies the education. It's become established. It is good in the sense that you can analyze performance and you can get feedback, so scoring and so on. The disadvantages obviously are high cost and the inability to achieve realism. However, there is such rapidly improving software that makes this more real that I think that, you know, we will be less inclined to think it's not very real in the future. So going on courses and workshops, really important. It increases motivation, without a doubt. You come back fired up, you want to do this thing. The attention is grabbed. It's important to use that to motivate you to learn the skills faster. And also you can get feedback and evaluation. Just be aware of one thing though. There's the sort of, I've done many training courses in Europe and we sort of dub it the delusions of grandeur. You know, you come away having whipped out a nephrectomy out of a porcine model or whatever, and you think now you can do a nephrectomy, and in fact you think that you are a hell of a lot better than you might be. But anyway, just bear that in mind. But there are definite evidence, there is evidence in the literature that it is beneficial. Box trainer, I would hope that people in the room all have had opportunity to use a box trainer. It is the one thing that you can do on your own, and one cannot underestimate how important it is. It gives you visuospatial perception and practicing suturing. When I went to Leipzig, I learned under Prof. Stolzenberg, and I was there for 3 months, and he said to me after about a month, and I had done tons of box trainer already, and he said, I believe you're progressing very well. The people are very, the feedback is you're doing excellent operation, but the boys tell me you can't suture. And I'm thinking, I cannot believe this. I've spent hours and hours and hours. The point is, it wasn't enough hours. So go back and you spend more and more and more hours. And I'd say you probably need to do, certainly in laparoscopy, at least 50 hours of suture training to be able to suture. 50. And that's probably not enough. Robotics is slightly different, but that's another discussion. So it is obviously low cost, very flexible. It's available, you can take it home. But obviously the anatomic fidelity is low because you're using all sorts of little bits and pieces. You're not necessarily using anything that's very realistic. So the representability of tissue texture is not there. But nevertheless, it is very beneficial. So obviously now we're lucky in robotics. I hope the video works, I'm not sure. Let's see.
Chris, you got the videos in a separate folder. You can show that way.
Okay, why don't I do them all at the end? You can just flash through them, yeah? So, so we now have the opportunities to do box training on the robot, and I'd strongly recommend that if you can get hold of that. This is just a video that you'll see later on the kind of thing you can use to practice anastomosis. Interestingly, this has now become very popular in Europe. It's the esophagus and the stomach, the gastroesophageal junction in a chicken. That's the perfect thing to mimic the urethral anastomosis. It's quite hard to come by because in Europe, it's a law that you can't actually sell the innards of the chicken. You can do the heart and the liver and all that in the little bag that goes up the cloaca, so to speak. But that part of it, you can't. So you've actually got to specifically try and source them. But that's a fantastic model to use. So animal labs, indeed, there's a lot to gain from them. And again, now the tissue texture is closer to the human anatomy, and therefore it's very valuable. You can also simulate complications. I think you've all seen these examples where actually you can make the, you know, the model bleed and all that sort of thing. And that's why it's very helpful in that sense. The disadvantages are that is expensive and it requires specialized personnel and, of course, ethical approval to use animals. And that is a big deal in the UK. It's been one of the stumbling blocks with animal labs. So all the, not entirely all, because there are few locations where it's allowed, but most people go to Europe to learn because it's easier there. And in terms of questionnaires amongst trainees, they far prefer the animal models to inanimate models and box trainer and all that sort of thing. So there is feedback. I've just picked a couple of slides just on some evidence, because there's loads of evidence out there, but what you need to understand is the evidence is not high level, and also it is quite contradictory and controversial in many aspects. But so one study will show a certain advantage in one thing and then it's refuted in another. So it's really tricky. It's a bit of a minefield out there. This was one where they used cadavers, porcine versus cadaveric models, and they had experienced people and residents. And what they found was that the tissue handling and the ability to dissect to anatomical planes was actually better in the animal model, but in the anatomic relevance, obviously the human cadaver was superior. And simulator is the next step. It is controlled, it's safe, you can get feedback, you can you can mimic real procedures, and I think without a doubt it does improve the psychomotor and visuospatial skills, and it's importantly allows that repetition of tasks, and you can interrupt it and get feedback, progress in that way, and it can provide a record. So if you want to go on a certain course, you must have proved that you've done so many hours on the simulator, because the record is there. You don't just take it from the trainee's CV, so to speak, you know. So these are just some simulator videos. We can see them afterwards. Cadavers, of course, that is very helpful. It does exactly, obviously, mimic the real thing. It's similar to animal models, but it is very hard to get to places that actually offer that facility. It's a high cost, and again requires centers of specific with those specific facilities. This is really important, the non-technical skills. So they divided into cognitive and social. And this, you will know from the operating theater environment, the chaos that normally prevails. Apparently, I mean, I've just been setting up this morning. It's incredible, and there's no fault of anyone. It's just everyone is doing their thing and so on. So when you get going, you need to have situational awareness. Incredibly important. How many times I've seen a registrar trying to change the camera, pushing it, and the bum is hitting the table, you know, of the sterile table behind it. It's incredible. So situational awareness, decision making, and planning. Very, very important. We have spent time this morning, at least half an hour, planning. Everyone knows what they've got to do. And it will ensure patient safety if you go through those steps. And the social skills, communication, teamwork, leadership, and ineffective communication may contribute to more than 40% of errors. And that actually does come up in medical legal cases. There's no doubt about that. So important, those softer skills as opposed to the hardcore technical skills, which I think people overlook. And finally, when you put all that stuff together and you've been through the various hoops in whatever form you can structure it, you land up with the real thing. You've got to do the procedure, and mentorship is the way to do it. So it allows that sharing of skills, knowledge acquisition, and it's in situ. So it's very real. And it's in this context that modular training becomes important. And this is dividing the steps of training into various levels of complexity, and only moving on once you've achieved proficiency in that particular level. So you don't put the patients at risk, and interestingly, you don't take so much time because there is a default for the mentor to take over when you finish that certain skill. Now, mostly mentors are in the same institution, which is fine because they're allowed to operate. And that's where the whole difference comes between a mentor and a proctor. The problem with a mentor is that very often they're not allowed to touch the patient, and they can't bail you out of trouble. And so you end up struggling for 6 hours or 8 hours or something, everyone getting a bit tired and the patient suffering and so on. So therefore, you've got to structure it in a very sensible way that you can have someone take over. That's what we've recently just got a dual console, and that's fantastic for that purpose. And I think in time, that's how we will train. So you also can go on fellowships, and that's tricky, but it is the way to go. There's no doubt about it. And telementoring, still in its early phases, but I think that will also come to the fore in due course. So because of the complexities of training in the final throes of the process, so to speak, structured training offered by an institution is obviously the way to go. You go through the whole steps of e-learning and through to the simulation, through to final procedural training. And this is what the European Association of Urology has actually developed curricula in urology and validated it. And in fact, this was the publication. And they offer that particular course. I don't know what your access is or possibility to go there, but that is something that as an institution, you should probably nurture and work on that relationship with ORSI Academy in Europe. And we can talk about that afterwards. But that would be a very sensible thing to do. This is just an example of our modular training at George's. So we have the different steps, and you actually put a date and it's signed that you passed a certain step, and you have to do it X number of times. And that's very useful. So we have an A4 page, and it's got to be done. So ORSI Academy, I have quite a lot to do with them, and state-of-the-art facility, really incredible. And there you can go through all the phases of training. This is, for instance, what they would do for the partial nephrectomy courses, e-learning, case observation, day 1, day 2, day 3. The whole thing is structured, and then you have modules, and it's all done in a certain period of time. Another example of some evidence in the literature here was just evaluating the use of a robotic surgical stimulator, and essentially using experienced and inexperienced people. They did show that the lab training in the simulator improved performance during live human surgery. And another one was a comparison between fresh frozen cadaver and simulator, and the fresh frozen cadavers perceived a significantly overall better model, which is quite sensible, I think. But the problem is access to the human, the fresh frozen cadaver is limited, and therefore we will be very dependent on high fidelity simulation rather. This is another video. I'm going to take this opportunity to give a bit of advertisement of the book that came out this week. It's a must read on renal cancer, and literally has just been published. So it's an all-encompassing journey through renal cancer, and it is really applicable for anyone who deals with renal cancer. It's not only surgical at all. There's oncology, psychology, big data, pathology, radiology. So it's really interesting, and you can buy individual chapters. You don't have to buy the whole book, but I'd strongly recommend it. Very famous people have edited it. Absolutely. Thank you very much. That was helpful. Oops, let's do the video. So where will we find them?
plek in die Kaap, die een wat nogal van 'n guy wat sê die wielerplek is geen wegpak. Dat is basically. Ja. Dan wat plek is die pyl. En jy weet hoe
Yeah. And I'm just going to talk through it.
okay.
Should we share it? Pause it one.
Yeah, just go with it. This one starts with slowly.
Here it is.
Yeah, so this is the gastroesophageal junction in a chicken. It'd be worth finding out whether this is possible to get hold of. I don't know how one would begin, maybe with a butcher or something. That's difficult, but it's a good way to practice. And of course, you can just cut out the where you've done the sutures and just keep redoing it. So you don't. It's not a once only model. And we've used it on the courses at Orsi with to great effect because it can and really does exactly mimic the urethra and bladder because of the more floppy gastric component simulating a bladder neck. So we can move on from there. No, let's go to where's the ring walk? Just do that one. 3.
Not sure if it's
You
shared.
gotta close that or
Somehow share it. That's strange. Have I opened it? Let's try again.
so again,
So it just has to.
yeah.
Sure.
Where is it?
Quarto braccio.
Yeah, that's Italians. So this is just a simulated model, and again, repetition, feedback, timing, all of these things are components of it, and make it quite a favorable way to do it. The idea is I find with trainees, a lot of times they do it once or twice and say, oh, I can do that. But actually, you want to achieve a certain level of proficiency and use that as a tool to have multiple repetitive attempts. Because at the end of the day, to be a good robotic surgeon, it equals many thousands of hours at the console, plus having the hand-eye coordination, etc. But it's console hours, and if you can do many console hours on the simulator, that's very helpful. There are 1 or 2 others, but maybe we can show Firefly because I'm going to do this one.
Bring the guy to present the case.
Yeah. So Firefly is something we use routinely. This is the immunofluorescence. And I just showed it because in fact we're going to do it today on a partial nephrectomy. And what it does is you use a 5 milligram bolus injection after you've clamped, and in about 30 seconds or so, you turn the console onto firefly immunofluorescence mode, and you can see it filling the perfused parts of the kidney. You can see in this case, unfortunately, it's behind the clamp. You can the tumor is actually at the top. So the tumor, which has had selective clamping, stays dark, and obviously now, well, after removing the clamp, you see it begins to perfuse, and that's how you know whether you've selected the right artery. It's very useful for polar lesions and cortical lesions, but once they become interpolar, it can be a bit more tricky as soon as you've got a combination of anterior and posterior supply. So you don't use it exclusively, but it's very useful if you want to do selective arterial clamp. I think that's it. What else is there? I think that's. I think probably we finished there. There are a couple of little other simulation videos, but we won't.
Yeah, no, thanks a lot. We can just load the charts. No, thanks a lot for that, Chris. It's really been very helpful. I think we also, I mean, I've been through this pathway of training to be a robotic surgeon. I've done 5-6 proctored cases, and it's exactly what you're saying. You know, one has to do observations. I've watched a lot of robots from Conray in private, and then obviously playing on the simulator. And like you said, we always stress that the more time you do, you know, because the requirements from MedHold is that you need to get 90% all the exercises, but you're quite right. That doesn't mean you're done. If you get all the exercises right and you think you're done, you just need to do more and more hours. Another interesting thing that I actually did is that Connie advised me I should watch the Big Patel prostate video. And I watched the thing many times. And I thought it helped a lot because essentially, I mean, what I had to do when I was doing the cases was exactly what it did. And it was quite easy to remember because I just remembered all the steps in the video that I actually watched. Is it something you'd recommend as well, expert videos?
Yeah, definitely. I think 2 things with respect to videos. You must watch the experts' videos, and I would recommend that you watch a few, because with the price of international travel, it's hard for you guys to go visit all these people. But I was lucky, and I was part of the sort of very early days, the pioneering days of robotics and laparoscopy. So we used to have to go and see people. And I know now, today, that I do a prostatectomy with a bit of Patel, a bit of Tawari, a bit of Stolzenberg, all in one operation. And you can only do that when you've seen lots of people operate. Now you can do that on video. You know what I mean? And I think that that's one thing. So, but the second thing, the most important thing, is for people to watch their own videos, because you cannot believe how terrible it looks, you know, when you're training. You're all over the show, and the economy of motion is poor. And that's what you've got to start realizing. You think, I got from, you know, this part to that part, and I did well. But then you go watch your video, everything's moving around, and it's just not very clever, you know. So watch your own videos and criticize yourself in the process.
All right, thanks a lot. We're gonna get Clive now to present the cases, but we'd also like to encourage you to do more holidays to SA now that you've showed our program. We really appreciate having you around. Thanks.
Thank you. Thank you, everybody.
Thanks. Good morning, everybody. Just a quick, just going to give a quick 2-3 slides on the cases that we're doing. So we know that this morning we've got a partial nephrectomy plan and then a radical prostatectomy via an extraperitoneal approach. So we'll just quickly start with the case which is about to go on now, so everybody knows our indications for this case. It's a 41-year-old gentleman, no chronic illnesses. He had an episode of stones, urinary stones, 2009, which received a laser. And then he's had a previous writing viral linear repair in the 1990s, but no obvious scars. I don't think it's going to be issues with mesh and that sort of thing. He's got sober habits. He's a father of 1, and he's employed in retail. And he's got no family history of malignancy or anything to suggest a VHL syndrome. In December of last year, he presented with a 1-week history of right flank pain and microhematuria. It was initially thought he might have another episode of stones, but his CT scan done showed this right lower pole renal mass, 4 by 3.8 centimeters, mostly exophytic, contrast enhancing, normal renal vein and IVC, and a normal contralateral kidney. use just some stills here on this coronal view here. You can see that right sort of lower pole renal mass on this actual view. It's probably about 50-50 endophytic, exophytic, and then on the sagittal view you can see it's more anterior. We give it a nephrometry score of about 5A, A obviously for anterior, which we think might be, based on that score, amenable to a partial. So he's been discussed. They say this is more in keeping with the Bosniak 3 cyst involving that kidney. As we know, Bosniak 3 has a chance of malignancy. He's currently clinically well. Still has intermittent right flank pain. It's a good performance status patient. He's a tall gentleman, big. He's got no clinical features of tuberous sclerosis complex. No abdominal scars, normal renal function. And this case has been discussed at the combined urology oncology meeting. And we felt the best plan for is a partial nephrectomy. So in the hands of Professor Chris Anderson, we will hopefully get to see a nice right-sided partial nephrectomy for this gentleman. And then we'll present the next case when the time comes.
Can you just put up the TT?
Sure. Should I go to the IntelliSpace or just the stills?
Can I just make some comments on the CT? So we can't scroll here.
Nah.
Lift it up. I can open it for you. All right.
Are we still sharing? So stop and then I reshare.
So this person, I just looked at his scans, appears to have a single artery. So that's the first thing I always look at. And I always say to anyone doing this, you must have in your mind, you must know exactly what you're going to encounter. So I look, in fact, where it is in relation to the vein. And vein coming up very high there, I think, not sure. This is the left. It's a rather odd configuration here. I'm not sure whether there's two, yeah, there are two veins here, you see. And then artery does split. There's an early posterior division that comes off. It's always the first division. And in this case, because it's lower pole, all we can do is spare the upper part of the kidney. So what we should do is find the arteries going to the upper pole, and that's what we will exclude, and we're going to clamp everything else. We've got to, this thing is quite anterior, and it remains to be seen intraoperatively. You need the axial view, but it doesn't matter now. But you need to see whether you can or can't get away with excluding the posterior division as well. And another thing to say with cystic tumors, you can't lever across the top of the tumor. In this case, it won't matter because it's quite exophytic. But if it was anywhere else in the kidney, particularly upper pole, you tend to find the inexperienced surgeon is trying to go over the top and down and actually levering on top of it. And of course, you can pop the tumor. So everything has got to be done around the bases, around the left side, the right side, and you circumscribe it as opposed to any work over the top. You can't afford to do that.
Just a question, sorry, Chris. If you're supposed to select the artery that goes to the tumor, you still stick to your 20 minutes or almost give me a time. Do you still do that? Because if you think about it, you're going to be cutting the area, some of it. Obviously, there could still be some kidney being confused by that.
Yeah, it's not so important.
Yeah.
Of course, but generally, we somewhere between 15 and 20 usually, and that's what we stick to.
Thanks.
I think we could ask some questions. We would like to do next door, obviously.
Yes. So, do you have any questions from the people that have joined us on Zoom this morning, or even from the floor here? Questions on the topic while we have our expert here? You can just unmute and ask a question, or even maybe you can type. We can go to your question. And the nephrometry score is quite a valuable thing to do because sometimes I think we do mostly open partial nephrectomies. And we found that sometimes we may overcall nephrology scores. And there's a few cases actually gone in, we thought masses were complex and be able to do it. Is it something that you do a lot, and then which one do you like? Nephrology scores.
Yeah, so I routinely use the Padua scoring. We do it all the time in our for our data collection. I think its main use really is for evaluation after the event rather than before, because to me, I can eyeball a case and know exactly what to expect, if you know what I mean. And I think all of us do that intuitively, is that you don't need a score to tell you, you know, it's upper pole, exophytic, half endophytic. You can see that. So I think it's a useful tool to be able to put into numbers and words what people are seeing on a screen. But as a surgeon, I don't need to know the Padua score. But I did use the Padua score when we showed what happened with our first 20 cases, our next 20, you know what I mean? And you said, in fact, I presented this at SAUA a few years back, you know, how many cases it takes to be proficient. And that was all based on complexity of the operation. And what is complexity? Complexity relates to nephrology scoring. It must do, because, you know, that describes where the tumor is. So I think it's very useful from that perspective, but in my gut, I can see and know what to anticipate without needing the score.
Chris, the patient is positioned, so we're kind of just ending off now. Two questions that often come up in the literature so much. Inda Begill pioneered the zero ischemia technique, and I was always uncertain, is this the way of the future or is the surgical vanity? And the second question is that there is suggestion that warm ischemia is reduced if you only clamp the artery and leave the vein separate. What do you think about those two questions?
Okay, so I've never ever clamped a vein. So you just simply don't need to. You've got the pneumoperitoneum to clamp the vein. And all you do is you crank up pressure. And so it's really not worthwhile, because the main reason is it's not really necessary. But the second thing is that by dissecting the vein, you are likely to cause more bleeding with complications and tear the vein and all that sort of thing. Because all you need is a lumber to pull off the back of the vein at the beginning of procedure, and you've got serious problems for the rest of the procedure, and you might have to open or whatever. So leave the vein well alone, just use it as a landmark, and then go for the artery is my advice.
Even for a beginner who wants zero blood loss, blood in the area?
There's simply no problem with leaving the vein alone.
Okay.
And the second thing is zero ischemia hardly ever used, because it's hazardous. You can only use it for the very tiny lesion that's very exophytic and cortical. Otherwise, I wouldn't even bother.
The learning care for partials?
Being fun?
The learning care for partial. How many do you need to do to be safe with the?
Well, we show that you should do 20 to get an ischemic time under 20 as an average, and we were 16 minutes. Padua 8 and below, 20 cases were needed to get to that sort of level. And thereafter, but it also depends what sort of experience you've had. If you've done lots of open partials and all that sort of stuff, then you will do better than someone who's a complete novice. So it's quite a difficult thing to know. Also, have you gone via laparoscopy to that endpoint? It's really interesting that the evidence simply isn't out there that laparoscopic proficiency results in a truncated robotic experience. However, everyone who's done loads of laparoscopy and learns robotics knows that that's absolute nonsense. There's hardly a learning curve when you've been through laparoscopic. And in fact, the evidence shows the opposite. They've shown studies with prostatectomy, how the novice who went from open to robot did better than the laparoscopic surgeon to robot. I just simply don't believe that. I mean, it takes honestly about 5 cases and you are up to speed if you've done years of laparoscopy.
Chris, can I ask, how do you assess competency? So I have some experience with that in the flexible endoscopic world,
Yeah.
where it's really quite a defined area where you can look at assessing competency. And in trainees, they use directly observed observation. So, and do you use directly observed observation as a tool for independent assessment for competency? And one of the other problems is that you and him and John learn at different levels. And obviously, the average urologist is the average urologist. He has reasonable motor, visual, spatial, psychomotor skills, but he's not an expert. So what these learning curves are very independent. You've alluded to some of the aspects which will dictate that in terms of prior exposure. So do you use DOPS, or directly observed procedural competency? And do you use, you've alluded to the key performance indicators that you've sort of alluded to. So
yeah, it's a difficult one to answer because it's a bit like saying when everyone has a driving license, and how do you assess the difference between them? It's much easier to ensure that a novice going through from the bottom gets properly trained than to take senior people or moderately senior people and assess their competency. So that's number one. The new buzzword is going to be called proficiency-based training, and they've shown with arthroscopy and some cardiac. These are completely non-laparoscopic. They are entities where they can create metrics, sort of steps, and basically the people who have passed those various metrics to a level of proficiency do better than in performance than actually experts just doing the thing themselves. So it's quite interesting. You need some stepwise proficiency-based way of doing it, and just observing is a component of that, not the whole thing. And that's the problem. So you need some simulated model, really. Case observation, some simulated model, some sort of stepwise proficiency-based way of assessing people, because otherwise there's too little information being gathered really by just observing.
Chris, thanks. Do you mind just confirming the position you're about to start now?
Okay, I don't know if that answers that, but it's a complex minefield. That
it is indeed. Thank you.
Good. Thank you very much, everybody.
Thank you.
Will someone take Chris Ryan? Sia, do you mind just settling him in there?
If you guys can just stay logged on, if you can just watch the live videos, you can just type the questions, we'll address them. Yeah, thanks a lot. Thank you to everyone who's joined us this morning.